Our first speaker today is going to present mobile gastrointestinal and endoscopic surgery in rural Ecuador, 20 years experience of Cinterandes. And our presenter is Hadi Shalabi. Hadi.
Thank you very much. Great. Thank you. So good afternoon, everybody. I'm Hadi. I'm a young surgical resident from Nottingham in England. And we're going to talk today about a very exciting research I performed, actually. It was examining mobile GI endoscopic surgery in rural Ecuador, and it was based on the 20 years experience of Cinterandes. So I have nothing to disclose. So just to start off with, the background is quite interesting, actually. So the Lancet Commission recently reported there's actually 5 billion people in the world that lack access to timely and affordable surgical care. And one of the main barriers is geographical access for the patients themselves. And typical factors are the distance and the poor road networks and the lack of suitable transport as well. And this was recognized in Ecuador by a surgeon called Dr. Edgar Rodas, actually in the 80s. And he had a vision that if people couldn't come and access the surgical care themselves, that he wanted to take it to them. And so what he did is he took about 15 years from him and his team to gather the necessary resources to build a truck and to build a team as well to function. Since 1994, they've been typically doing about 1 or 2 missions a month, and they've accumulated over 7,600 operations, which is a phenomenal number, really. They've traveled 300,000 kilometers, which is around 8 times the circumference of the Earth, and they've traveled to the very rural and remote areas in Ecuador. So this research really examines their methodology, and it's based on a 6-week field research where we conducted interviews with the core and founding members, as well as examining the documents and internal records. Start off with the truck itself. So this is a 24-foot truck, which was built in US but designed in Ecuador. The dimensions were limited for the road limitations, and because of the Andes mountains and the small passes, it had to be a medium-sized truck. There's 2 main sections. There's the preparation room, where the surgeon will enter, and there's scrubbing facilities and a lot of the equipment there. And this is from where the patient also enters. And then the second room on the left is the operating room itself, and that's got the operating table. It's got all the anesthetic equipment, the portable anesthetic machine, laparoscopic tower, and the rest of the surgical equipment. And from there, the patient is taken round the back, through the rear, to a portable bed, where he's taken back down to the ground by a hydraulic ramp. Just to go over the structure of the program itself. So there's 5 main stages to it, really. There's the first stage is the patient identification stage. This happens this is conducted by the local medical personnel in the rural and remote areas itself. And they shortlist patients who may need surgery. So they spread the word that the truck may be coming, and who might require surgery, who's previously been seen in any clinics or have surgical problems. And they have exclusion criteria as well to exclude patients who wouldn't be suitable for mobile surgery, to refer them to hospital care. Second stage is the pre-operative assessment. This happens around a week before the mission itself. This is usually conducted either by the Cinterandes staff or also by the local medical contact and supported by video consultation with the staff, depending on their competencies. And this is usually done to save time on the mission, so any investigations or anything beforehand can be arranged for. Then there's the surgical missions themselves. These are typically around 4 days, and 1 day prior is when the truck arrives in the rural or remote area. They usually park next to a health facility or next to a school or even just in the center of the community. And there are usually 2 to 3 surgeons, and they rotate between one another to allow for constant operating time. The fourth stage is the primary post-operative care. Now, this is carried out or supervised by the Cinterandes staff, but one of the unique sides of it is that it's conducted in the community itself. And most of the time there are family members and friends around, and it does have a very positive impact on the post-operative outcomes as well, and the recovery. And finally, the fifth stage is the secondary post-operative care. So after the fourth stage, the care is handed over to the local medical personnel. And the secondary post-operative care is usually carried out 1 week after, 1 month, 6 months, and a year. And it's usually done by video consultations through the use of the internet. And if that's not available, by telephone communication as well. With not just with the patient, but with that local medical personnel who runs a clinic. And this has been developing over the last few years at an astounding rate, really. The devices available in Ecuador are phenomenal. So there's around 15.5 million population of Ecuador, and there's actually 16.5 million cellular phones. So most people actually have a cellular phone anyway. And lastly, the types of surgical operations. So the GI endoscopic surgery is one of the most suited because of the nature of the operations, the nature of the equipment required is very suitable for truck-based surgery. And the post-operative care as well is usually manageable in the community. The complication rates of Cinterandes have been well below 1%. There have been no mortalities over the 20 years that they've functioned. And just to give a flavor of the kind of operations that they do, the table in the bottom right is the different various surgical specialities. So these are operations from 1994 up until 2014. So around 60% or over 60% were actually general surgical operations. And within this, over half were cholecystectomies and hernia repairs as well. So in conclusion, mobile surgery has really enabled the Ecuadorians the Ecuadorian healthcare system to reach out to the inaccessible, really. In this case, the 7,600 patients that they have operated on. It's not without challenges, namely the governmental and financial barriers, as well as maintaining a good team. And it's important that it addresses all the aspects of perioperative care. We hope that this paper will act as a guidance for other countries and other systems that they may adopt and adapt the approach of mobile surgery to reach out to their inaccessible patients. Thank you.
Are there any questions for Dr. Chalabi?
Dr. Habit, I know the work from Dr. Rodas in Ecuador, and I'm sure it's very important for the country because the Indian population is very big and the geographic problem is really very hard. It's a very good job. Congratulations.
Yes, please. Name and institution or city, please. Thank
I'm
you.
Allison Porter from the University of Washington. Thank you for your presentation. The first operation I ever scrubbed into was in 2003 in that very truck. And I'm very inspired by the work that's happened. My question is, are they going to need to replace the truck? I assume it's aging. And my second question is, has the proportion of laparoscopic surgery performed in the truck increased over time, or is it remaining stable?
Thank you. So, regards to the first question, they're actually in the process of buying a new truck. The unfortunate incident is that Professor Rodas, he passed away 2 months ago, and he was the main drive for the truck and the management of the truck itself. And so there's had to be a reshuffle of the management itself. But they were in the process of buying a new truck, one that can also expand sideways to allow for more space inside of the operating theatre. And just to finish that off, I think they're just securing the final parts of financing that. For the second question, I do believe that laparoscopic operations have increased over time. One of the main reasons is because of the familiarity of the surgeons performing them over the last decade or even 2 decades has increased. And also, as you rightly mentioned, the suitability of laparoscopic surgery in these rural and remote areas where fast post-operative time and a lower rate of complications is very, very important, and it helps avoid readmission or admission to a hospital or even critical care. Thank you.
I think we have one more question. Thank you.
Thank you. My name is Juan Blondet from the University of California, Irvine. First, I want to say this is a fantastic idea. It's really good for very rural places, especially in South America. I have 2 questions. The first one is, how do you and how much time it takes you to re-sterilize the surgical suite, meaning for the next procedure? And the second question is, how do you make sure, I think you briefly mentioned the post-operative care, like nursing access and all that in these rural areas?
Okay, thank you very much. So for the first question, the system I believe that they do is they have one very thorough scrub every morning where they go through the entire operating theatre and really scrub it down very thoroughly. Then between operations, from what I've seen, it's usually around kind of half an hour or so where they, again, clean and scrub. Each team member has a specific role, and there is one gentleman who is particularly responsible for managing of the equipment and also of making sure everything is sterile and making sure everything is clean. So it's his role immediately after the operation is done to participate in that. The second question, I have forgotten your second question. Yes. So it was about the kind of post-operative care. So it's a very important point that you've raised, actually, in that it's quite easy to take a truck and to operate on these patients and then to leave. But actually, what happens if something goes wrong? And the time they're there is limited, so it's 4 days. And so if a patient on that very last day of the operation, something happens, what then? So the system that they have is that, like I said, there's that local medical contact. Now, I don't believe they will travel unless they have identified somebody there who has some basic skills for healthcare, either a nurse or even a midwife, somebody who understands. And they are the ones that are left in charge of the patient. Now, I don't think the team leaves until they're satisfied that all the patients are likely to recover fine. If there are any serious complications at the time, then they will rejig their schedule so that they take care of that patient. The surgical team is available they're always available by phone call, first of all, and then they are also available for a home visit, so to revisit that area that they've just been to if there is a need for that patient. It's only happened on very, very rare occasions. And last of all, they try to identify a hospital if there is a need to transfer that patient to appropriate places.
Great. Thank you very much.